Bismillah ar-Rahman ar-Rahim. Today's lecture is about neck masses and how to evaluate them. And my name is Associate Professor Dr. Hatem Alwagih. I'm an Associate Professor of Surgery, Head and Neck Endocrine Surgery Unit, Surgery Department, Faculty of Medicine, Alexandria University. We need to evaluate neck masses because we need proper treatment reaching the best prognosis or outcome. The learning objectives of today's lecture are, number one, to describe a systemic method for evaluating patients with neck masses. Number two, to suggest the appropriate diagnostic studies. Number three, at the end of this lecture, you need to be able to discuss the differential diagnoses of neck masses. Number four, at the end of this lecture, you will be able to describe the outlines of surgical treatment of neck masses. This is the very famous classification of neck masses. They are classified into congenital and acquired, and the acquired masses are classified into inflammatory, benign neoplasms, and malignant neoplasms. So congenital and benign and malignant. Congenital, inflammatory, benign, and malignant. So, all masses can be derived from either the skin or the endocrine system, the thyroid and parathyroid glands, the upper aerodigestive tract, the pharynx, the larynx, the vessels of the neck, the carotid, the lymph nodes of the neck. We start the approach to evaluation of neck masses should start with appropriate initial assessment. Then we need to discuss and you need to know about the role and technique of fine needle aspiration biopsy. Number three, the third pillar of the approach of evaluation of neck masses is the appropriate use and interpretation of imaging. And ending with the management of neck masses, the management. And we need to stress upon the importance of a specialized multidisciplinary care, especially if malignancy is suspected. So 4 pillars: appropriate initial assessment. Number 2, the role of fine needle. Number 3, imaging procedures and interpretation of those imaging procedures. Number 4, the management, how we manage. The appropriate initial assessment need to follow the scheme. We need to specify the age of the patient, the location, risk factors, symptoms, and we need to do head and neck examination, and we need not to forget the general physical examination. So, number 1, age. Number 2, location. The risk factors of head and neck cancer, and when I say head and neck cancer, I mean squamous cell carcinoma. Symptoms of different types of neck masses, especially head and neck cancers like head and neck squamous cell carcinoma, head and neck examination, and we need not to forget again the general physical examination. So number 1, we'll talk about the age and the location. So age and location. Age, first age, right? All right. So pediatric age group. We have, as we said before, 3 main categories of neck masses: inflammatory, congenital, and malignant. The number 1, in terms of frequency, at the pediatric age group, you might think that it's the congenital neck masses. No, it's not. It's the inflammatory. So inflammatory is the most common among pediatric age group, in the pediatric age group. Number 2, the congenital masses. Number 3 are the malignant masses. When you jump to the young adults, congenital comes first. Young adults, congenital comes first. Number 2, the inflammatory, then the malignant. Here, as you might think that in the adults, you may think, and you are sure thinking about, in the adults more than 40 and the age group more than 40 years of age, malignant jumps to the first rank. Malignant masses comes first. Then congenital and inflammatory becomes last. So 3 main categories: inflammatory, congenital, and malignant. Pediatric age group, inflammatory first, congenital, malignant. Young adults, congenital first, then inflammatory, and lastly malignant. And in the age group more than 40, malignant comes first, then followed by the congenital masses, and then lastly the inflammatory masses. Well, what about the location? Here, that's a scheme, a diagram that will show you the famous locations in head and neck masses. At the angle of the mandible, of course, you think about the parotid salivary gland. Number 2, in the lateral compartment of the neck, most famous, lymphadenopathy, lymph nodes, masses originating from lymph nodes. Central compartment, medial, the midline neck masses. The thyroid, the most famous midline neck mass. When you consider the age and location of patients with age of patients and location of neck masses, especially in the adult with a lateral neck mass, it jumps to your mind, should jump to your mind the famous rule of 80. So lateral neck mass in adult patient. Neck mass in adult patient, lateral, 80% neoplastic, and the remaining 20 inflammatory or congenital. Of those 80% neoplastic masses, of those 80% are malignant. So 80 of the 80 are malignant and 20% are benign. Of those 80% malignant neck masses, 80% are secondaries. The primaries, metastatic or secondaries from primaries, whether in the head and neck region or in the subclavicular region, and only 20% are primary. So again, adult patient, lateral neck mass, 80% neoplastic. Of those, 80% are malignant. Of those, 80% are metastatic secondaries. All right. So what about the risk factors? Risk factors of development of head and neck cancer. When I say head and neck cancer, I talk about squamous cell carcinoma of the neck. Tobacco, smoking kills, right? So tobacco, alcohol consumption. And when you look at this table, you find that if there is no alcohol consumption and there is no smoking, normal adult with no alcohol consumption and no smoking, the risk is 1. When you jump to yes and yes, yes and yes, it jumps to the risk multiplies by even like 5, 6, 5.71, right? So you see, alcohol plus smoking, the risk is 5.71. 6 times, almost 6 times more than the normal person. Well, so other risk factors is sexual behavior. Again, I'm talking about squamous cell carcinoma of the neck, of the head and neck region. Squamous cell carcinoma of the head and neck. Human papillomavirus and head and neck cancer. It has very important relation between human papillomavirus and head and neck cancer. Number 1, there is a male predominance. Younger patients, fewer traditional risk factors like smoking, like alcohol consumption. So if your sexual behavior, if the sexual behavior of the patient, of the adult is not like okay, so there is it might happen in patients with fewer traditional risk factors. Sexual behavior as a risk factors. Well, who are those persons that carries the highest risk with sexual behavior, multiple sexual partners, more than 6. Number 2, there is a higher rate of affection of the head and neck region with squamous cell carcinoma in patients who are practicing orogenital contact with multiple partners again. Again, the very famous sun exposure as a risk factor of development of cutaneous head and neck cancer. So, what are the symptoms of head and neck primaries? Sore throat, otalgia, especially if it is unilateral, nasal obstruction leads to snoring, unilateral hearing loss, dysphagia, epistaxis, hoarseness of voice, and hemoptysis. So those are the very famous symptoms of head and neck cancer. If your patient is suffering from head and neck primary squamous cell carcinoma, sore throat, otalgia if it is unilateral, nasal obstruction, unilateral hearing loss, dysphagia, epistaxis, hoarseness of voice, and hemoptysis. So I told you before that it might be malignant due to primary tumors, right? Primary tumors in the neck. So what are those? Primary tumors, not metastatic, like lymphoma. Lymphoma is a systemic disease, right? It's not exclusive to the head and neck region. So how would you suspect lymphoma? Generalized lymphadenopathy, as you see here. See? Cervical, axillary, and inguinal, right? Iliac. Well, so are there any general symptoms? Any constitutional symptoms? Yes, of course. The very famous B symptoms of lymphoma: fever, night sweats, and weight loss, right? So, what is the importance of physical examination? What do we need to document? What do we need to document during physical examination? What is the location of the mass in the neck? It's very important. Number 2, the presence and absence of a primary in the head and neck region. So you need to identify whether there is a primary in the head and neck region or not. So location, where is it? Number 2, the presence of primary in the head and neck. Number 3, the presence or absence of a generalized disease, like generalized lymphadenopathy, and hence this highlights the importance of general physical examination. Very good. So local examination of the head and neck to determine the location of the mass in the neck and if there is presence of a primary in the head and neck region, and you need to perform a general physical examination to detect the presence of, or absence, of course, the presence or absence of generalized lymphadenopathy. So, of course, the very famous triangles and levels, level 1, level 2, level 3, level 4, level 5, and the anterior compartment or the central compartment of level 6. So, considering lymph nodes in level 1, if it is a secondary, as I told you before, 80% are secondaries, right? So if it is a secondary, the metastatic lymphadenopathy comes from the oral cavity and skin in level 1, submental, submandibular, right? It's not anymore, not submental, submandibular anymore, it's level 1. In level 2, what we call upper deep cervical, what we used to call upper deep cervical, all the jugulo digastric lymphadenopathy. So metastases from the oropharynx, level 3, middle deep cervical, metastases in lymph nodes, metastases from primaries in the larynx, in the hypopharynx or the thyroid. Number 4, supraclavicular, metastases in lymph nodes from primaries from the thyroid or primaries from below the clavicle. And if it is on the left side, you need to consider what's called the Troisier sign. Left supraclavicular metastatic adenopathy from pancreas, from colon, from stomach, and so on. Level 5, posterior triangle lymph nodes. metastases in lymph nodes from the nasopharynx, or from the nasopharynx to posterior triangle, level 5. So you need to complete the physical examination with physical examination of the primary, in the possible primary, in the head and neck region, in the oral cavity and oropharynx. Here are the common sites of early, the distribution of early squamous cell carcinoma. The lateral tongue, the base of the tongue, see? The base of the tongue and the lateral tongue, right? So distribution of early oral cancer, the lateral tongue and the base of the tongue. Well, how to detect those? You need to palpate the base of the tongue, and you need to perform the fiber optic nasoendoscopy. The fiber optic nasoendoscopy. Here, this is very funny. Most of the junior doctors, students, junior doctors, all of us, while practicing surgery during our early career, we might be faced with what we think that it's a neck mass. Like what? Like the transverse processes of cervical vertebrae. What else? Here, the carotid bulb. You can feel the carotid bulb and you might think it's a mass. It's not. That's what we call the non-mass. So the transverse process of cervical vertebrae, the carotid bulb, and the inferior belly of omohyoid. See, you can feel it and you might think that it's a mass. It's not. So you need to think twice. Transverse processes of cervical vertebrae, the carotid bulb, and the inferior belly of omohyoid. Here again, the importance of general physical examination. Generalized cervical, axillary, pelvic, inguinal lymphadenopathy in cases of lymphoma. The second pillar is the role, and second pillar of the approach of evaluation of neck mass is the role and technique of fine needle aspiration biopsy. Well, this is how we do fine needle aspiration biopsy, and the needle size is 25 gauge. You need to perform 12 to 15 passes, and there should be an immediate assessment of adequacy by a pathologist, of course. So why it's important? It is very important because it diagnoses other types of cancers rather than the differentiated carcinomata. How? It extends the benefit of fine needle aspiration biopsy now. It becomes more and more diverse. How? Using the technique of immunohistochemistry, the immunohistochemistry techniques. It can diagnose poorly differentiated malignancies, can diagnose lymphoma. How? Using the CD45, CD30, if it is CD45 or CD30 positive. And if, in cases of squamous cell carcinoma, if cytokeratin is positive. So in terms of diagnosis of the nature of lymphadenopathy, the fine needle aspiration biopsy carries a sensitivity reaching up to 97% and a specificity of almost 100%. But sometimes it becomes non-diagnostic in 8 to 16% of patients, and it recommends, the pathologist might recommend open biopsy in 22 to 30% of reports. Here is the open lymph node biopsy, which might be maybe incisional or excisional according to the case, and how far can you go with the excision of the lymph node. So here, as you see here, the incision should be at the skin crease, and this is the lymph node exposed here, and you go and excise it. So it might be excisional or incisional, and excisional or incisional as two types of open biopsies might be indicated or might be necessary to subclassify lymphomas. Fine needle cannot do that. Number two, to facilitate the diagnosis of poorly differentiated carcinomata. Number three, in cases of, as I told you before, persistently non-diagnostic fine needle aspiration biopsy. Persistently non-diagnostic. Then the third pillar of the approach of evaluation of neck masses is the appropriate use and interpretation of imaging. We use different techniques of imaging: CT, MRI, ultrasound, CT, MRI, ultrasound, PET scan. So CT, MRI, when? In adults with a lateral neck mass to assess a possible primary. So two indications: adults with a lateral neck mass, so CT or MRI, assess the possible primary. Ultrasound in children, in children. So you use ultrasound in children, and in central compartment lesions in all ages, thyroid lesions, central compartment. Ultrasound is the mainstay line of investigation besides fine needle aspiration biopsy in thyroid lesions. PET scan is very important in designing multidisciplinary planning for selected malignant tumors. So PET scan, it can detect metastases all over the body, and it can detect a hidden malignancy, an occult primary. Here are some preferred imaging modalities for neck masses or adenopathy in adults. So there are some scenarios here, different scenarios shown in this table. A non-pulsatile solitary mass or multiple neck masses. If it is a solitary or multiple, you need to do contrast enhanced CT. If it is pulsatile, contrast enhanced CT and contrast enhanced CT angiography, right? Logic. Pulsatile, so angiography has a role. In a patient with a neck mass and history of cancer treatment, contrast enhanced CT or CT PET scan. So you combine the CT and PET scan in patients with a neck mass with a history of cancer treatment. It's very effective. Then we jump to the fourth pillar, the management, with emphasis on the importance of specialized multidisciplinary care if malignancy is suspected. So treatment is different according to the diagnosis. So benign and malignant, right? Benign masses, malignant masses. So we'll discuss first the characteristics of non-malignant neck masses. Non-malignant, benign, inflammatory, non-malignant, right? So benign, inflammatory. Number one, a very famous congenital lesion, which is cystic hygroma, or the other old name is lymphangioma. It's a congenital lesion. It usually presents within the first year of life in the posterior triangle of the neck. It usually remains unchanged into adulthood, so it can remain unchanged until the patient reaches adulthood. It's soft, characteristic, soft cystic, multilocular here. Can you see the loculi, the honeycomb appearance here? Yeah, 1, 2, 3, right? So soft, cystic, multilocular, partially compressible, and the very characteristic feature, brilliantly transilluminant, and may present with pressure effects. Of course, if it is so big, it might give pressure, exerts pressure on the upper aerodigestive tract, for example, dysphagia, dyspnea, maybe. Okay, CT or MRI maybe, right? So it's a soft tissue lesion, so MRI, right? So CT or MRI may help to define the extent. So because it sometimes extends into the root of the neck, into the axilla or the chest. So it goes from here to the axilla, through the root of the neck, or to the mediastinum. So it may help, CT or MRI, and preferably the MRI, may help to define the extent of the neoplasm. Treatment of cystic hygromas include injection, sclerotherapy, or excision of easily accessible lesions. Easily accessible lesions, or those affecting vital functions. Because if it is affecting vital functions or vital structures, the injection is very, very hazardous. So a second congenital lesion or another congenital lesion is a branchial cleft cyst. So it originates, the very famous branchial cyst or a branchial cleft cyst, it's a remnant of the branchial cleft, especially the second one. It most commonly occurs in the second or third decade of life. See, second or third decade of life, despite it's congenital. So early adulthood. Pain, plus or minus, it might be a presenting feature due to what? Yes, true, due to secondary infection. So if it is not affected, it's not painful. Maybe a very mild dull aching pain, but if infected, it leads to severe throbbing pain. Usually presents as a smooth, fluctuant, non-tender if it is not infected, or tender if it is infected, non-transilluminal mass. You remember the cystic hygroma? It was brilliantly transilluminal, but here it's non-transilluminal mass. Underlying, that's very important, the anterior border. This is the anterior border of sternocleidomastoid muscle, and it's located underlying the anterior border of sternocleidomastoid muscle. If infected and bursts to the skin, it leads to the formation of branchial fistula or sinus. See here, branchial sinus. The primary treatment is, of course, if there is infection, you need to control infection by antibiotics, and then followed by surgical excision. Number 3, thyroglossal duct cyst. Thyroglossal duct cyst is a common congenital midline neck mass. We see them a lot. Sometimes at the lateral edge of the thyroid cartilage. So it's a midline neck swelling, but sometimes it deviates to the lateral border of the thyroid cartilage. So here, this is the cyst here, see here. So pain and tenderness plus or minus according to what? Yeah, correct. According to if it is secondary infected or not. It can be moved transversely but cannot be moved vertically. If you hold it with your fingers, and you try to move it, you can move it transversely from side to side but not vertically. So, but it moves upwards on protrusion of the tongue. So if the patient protrudes his tongue, it moves upwards. What about the treatment? Treatment is with initial control of infection with antibiotics, followed by surgical excision, including the middle portion of the hyoid bone, not only the cyst. You need to go up there and excise the middle portion of the hyoid bone. This is called cyst trunks procedure. You might follow the thyroglossal tract into the foramen cecum. Yeah, so you go up there through multiple incisions, step ladder incisions, to the central portion of first to excise the cyst with the middle portion of hyoid bone up to the foramen cecum. One of the very famous, actually it's the most common benign soft tissue neoplasm in the neck is lipoma. They are poorly defined in the neck. Lipomas are poorly defined, and they are soft masses. Usually, after it happens after the 4th decade of life, they are usually asymptomatic and soft. MRI is the best scan, and fine needle helps in diagnosis. Surgery is indicated when the lump is increasing size, leading to disfigurement, and the patient comes to you complaining of disfigurement, and when there is a doubt about the accuracy of the diagnosis, if you are suspecting a malignant version of lipoma, a liposarcoma maybe. So here, one of the very common masses is the sebaceous cyst, and it occurs often in older people, but it can occur at any age, of course. They are slowly growing lesions, masses, but sometimes, actually all the time, fluctuant, but it becomes more fluctuant when it becomes secondary infected, right? So it becomes painful and more fluctuant when infected. Diagnosis is clinical. Clinical diagnosis. How? You cannot pinch the skin over the swelling, and you might see the punctum, a black dot here, a black spot here, the punctum here. Excision biopsy confirms the diagnosis, of course, and it's the treatment, and it confirms the diagnosis. The benign cervical lymphadenopathy, most important one is acute lymphadenitis. It's a tender swelling, and you need to provide all patients with antibiotic trial if it is tender. And less acute inflammatory nodes generally regresses in 2 to 6 weeks. If the lesion does not respond in 2 weeks, you need to consider biopsy. Of course, it carries a higher risk here. In this scenario, if it does not respond, I didn't say complete resolution, but if it does not respond in 2 weeks, so you need to think of malignancy and you need to resort to biopsy. Another form of benign lymphadenopathy or non-malignant lymphadenopathy is cervical lymphadenitis due to tuberculous cervical lymphadenitis. It happens in the upper and middle deep cervical lymph nodes. The onset is gradual pain, plus or minus, again, plus if there is pain in cases of secondary infection. Systemic symptoms, you might be astonished that it's unusual in young adults, in young patients, and there might be development of an abscess in cases of secondary infection. The lesion becomes painful and increases in size with the skin discoloration. The masses are indistinct, firm, matted, and it fluctuates due to cases degeneration, right? The temperature, yeah, it's cold abscess, right? So there is no hot lesions here. It's cold abscess, only hot, and only becomes hot if it is secondary infected. Treatment with the famous anti-tuberculous regimens for 6 to 9 months. And here is another non-malignant lesion, which is a carotid body tumor. It's a rare tumor of chemoreceptors, and it happens at 40 to 60 years of age. It's a slowly growing, painless, sometimes pulsatile lump, and it might be bilateral. One of the main characteristics is that you can move it from side to side, but not vertical, not along the carotid, side to side, right? There might be symptoms of transient cerebral ischemia because it compromises the blood flow to the brain. There is a very famous term describing the carotid body tumor. It's called the potato tumor. Why? Because it's hard and not tender. Firm to hard and not tender. Palpation of this tumor, you need to take care. It might induce a vasovagal attack. Biopsy, of course, is contraindicated. Right? It's a vascular lesion, right? Vascular tumor. So vascular mass. So biopsy might lead to fatal hemorrhage, and it's contraindicated. MRI angiography is the investigation of choice, as you see here. See, this is the mass here. Surgical removal is mandated by the patient factors and presenting symptoms. If the presenting symptoms is severe and the patient is still young, so young I mean 40, not 70, 40, so you need to excise the lesion, you need to try to excise it. So risk-benefit ratio tells you in young patients that you need to give it a try. Here, a young patient with an incision here, see, there was a previous trial of excision, and here, See, the two carotids are separated by the tumor and the dye here. See the dye? How vascular is it? And this is the lesion after excision. Another form of non-malignant masses are the pharyngeal pouches. Pharyngeal pouch. It's a diverticulum of the pharynx through the gap between the horizontal transverse fibers of the cricopharyngeus muscle below and the lowermost fibers of the inferior constrictor muscle. So horizontal cricopharyngeus and oblique inferior constrictor, and the pouch comes from here, descends like this, emerges like this. Well, so presenting symptoms, halitosis. Why? It contains food. Stagnant here in the pouch, so leads to bad odor, halitosis, with regurgitation of froth and food. And there is no bile in this regurgitation, right? It comes from the pharynx, no bile or acid taste to it. And the pressure on the swelling, if you are examining the patient and you perform a pressure on the swelling, it causes gurgling sounds and the regurgitation of food inside the mouth of the patient. So what is the treatment? Cricopharyngeus myotomy to release the pressure there. Number 10 of non-malignant lesions, non-malignant masses, it's Ludwig's angina. It's a rare lesion but serious connective tissue infection of the floor of the mouth. Connective tissue infection, mostly due to dental infections, comes from the lower incisors. Signs of inflammation are always there, and the treatment is drainage of pus and antibiotics to cover aerobes with the anaerobes, so covering both organisms, aerobes and both categories, aerobes and anaerobes. And why it's serious? Because it might lead to suffocation. Patients might die from suffocation. Thyroid masses, the famous thyroid masses. It's the common cause of anterior compartment neck mass in all age groups. Especially young adults, but in all age groups, with a female predominance, and mostly they are benign. The fine needle aspiration cytology or biopsy of the thyroid mass has become the main standard, the gold standard of care, and ultrasound may show that the lesion is either solid or cystic. So both fine needle aspiration biopsy and ultrasound. See, a midline neck mass. Unsatisfactory aspirates of the fine needle should be repeated, and negative aspirates should not be considered as benign, should be followed up with a repeat fine needle aspiration biopsy and examination in 3 months' time. Well, we jump to the characteristics of the, so we finished the benign neck lumps. We jump to the malignant neck lumps. Lymphomas, first, it's painless, non-tender, smooth and discrete nodes, painless, non-tender, smooth and discrete, slowly growing. Patient presented with malaise, the B symptoms, malaise, weight loss and pallor, fever and rigors, and when you are examining the abdomen, you might find a hepatosplenomegaly, and if there is a mediastinal affection, a mediastinal mass, it leads to compression of the superior vena cava, leads to the what's called superior vena cava syndrome. If there is abdominal mass, there might be a pressure on the inferior vena cava and might lead to bilateral leg edema. And you need, again, to do, laying very much stress here again on the importance of general physical examination. So you need to detect if there is any other lymph nodes in the axilla, groin, and abdomen. Treatment according to the stage. It's a very radiosensitive disorder. The second one, and the commonest, 80%, you remember? commonest, 80%, metastatic lymphadenopathy. So upper cervical lymph nodes, upper aerodigestive tract. Accessory chain, level 5, the posterior triangle, nasopharynx, you remember? Occult primaries, that are the primaries that we diagnose via the detection of metastatic nodes, are the most common sites of them are the tonsils, the base of the tongue, nasopharynx, and biliform sinus. And you need to consider the metastases in lymph nodes and the left supraclavicular nodes, the Virchow nodes from abdominal and thoracic malignancies. Metastatic lymph nodes are painless, non-tender, and hard. Not necessarily hard. Late stage of the disease is hard, right? But early it might be firm. So you need to take care. Not all of them are hard. The workup, you need to search for the primary. It's metastatic, right? Secondary. So you need to search for the primary and deal with it, right? So again, the neck masses, to sum up, it might be at the angle of the mandible, the parotid, right? So possible, right? Possible lesion at the angle of the is parotid. What do you need to do? Fine needle aspiration biopsy, CT and MRI. Number 2, in central compartment, mostly thyroid, fine needle aspiration biopsy again and ultrasound. In the lateral compartment, children, you need to differentiate between children, mostly benign, as I told you before, benign. What do you need to do? Ultrasound. Children, you remember? Children, ultrasound. Adults, you need to consider malignancy, so you need to do CT MRI and fine needle aspiration biopsy. Again, the process of evaluation of neck masses starts with history, age and location, physical examination for the primary lesion, and do not forget general examination, investigations, fine needle, and imaging, and lastly, the ideal treatment which leads to best prognosis. Thank you so much.